Well, I would like to thank the organization to let me explain our experience with SS-OCT. We measured choroidal thickness automatically with SEP-SOURCE in chronic Vogt-Koyanagi-Harada disease. Well, as you know, SS-OCT may provide a safer and non-invasive quantitative and more objective approach to follow up chronic BKH. The course of chronic BKH is typically assessed qualitatively using indocyanine green angiography. In this study, we assessed the clinical value of automated measurement capabilities of SS-OCT to measure choroidal thickness, a quantitative approach. A prospective longitudinal case control study was done in a tertiary university hospital during 3 years follow-up. 25 chronic BKH patients were classified into 2 groups, a recurrent group with more than 12 weeks since diagnosis on treatment because of recurrences, and a quiescent group with more than 1 year without treatment and no recurrences. Subfoveal choroidal thickness was automatically measured with SEP-SOURCE using Triton, and an individualized analysis was done. Changes in thickness were compared to changes in visual acuity and ICGA findings to check for correlations. Here is the demographic tables. As you can see, we are going to talk about the chronic group. There was no statistical difference between gender and age with a control group. And the results were, from one hand, choroidal thinning and improved vision were associated with treatment. An increasing thickness and worsening vision were associated with a posterior relapse. Recurrent group had 24 posterior relapses, 41.6% asymptomatic, with no visual acuity changes. Quiescent group had 4 posterior relapses and 25% asymptomatic. All recurrences were diagnosed with SEP-SOURCE showed signs of inflammation on ICGA. Here is the table of the relapses of the recurrent group. As you can see, there were 24 relapses, 10 of them asymptomatic, 41.6%, and what we saw was that loss of visual acuity was not correlated with the amount of increase of subfoveal choroidal thickness. For example, the minimum choroidal increase without loss of vision was 50 microns, whereas the maximum choroidal increase without loss of vision acuity was 300 microns. Here an example with only 21 microns of increase and loss of vision. And here is the table with the relapses of the quiescent group. There were only 4 relapses, only 1 without loss of vision. And here also the same. The loss of visual acuity was not correlated with the amount of increase of choroidal thickness. For example, there was a choroidal increase without loss of vision with 48 microns of increase, and a choroidal increase with maximum loss of vision of visual acuity, and an increase of only 25 microns. And here we are going to have several examples. Here is a bilateral relapse, symptomatic in right eye and asymptomatic in left eye. As you can see, there is a correlation between the information that we have with ICGA. As you can see, there are much more signs of inflammation with the angiography, comparing right eye to left eye. And also the same, we have much more information of inflammation with SEP-SOURCE. As you can see, this eye before the relapse had only 297 microns in the subfoveal area, whereas at the relapse, the thickness was 916. There were also multiple subretinal detachments. On left eye, the increase of choroidal thickness was not so important, and also that eye had no visual loss. Here is another example of a patient with an asymptomatic bilateral posterior relapse and signs of inflammation on ICGA. Here, the relapse was asymptomatic, and of course, there was an increase of choroidal thickness from 264 to 478 microns on right eye, and from 310 to 562. Another interesting example, this was a man with a bilateral asymptomatic relapse in whom the choroidal thickness before the relapse was very thin, only 173 microns in right eye, and also very thin in left eye. At the relapse, the thickness was, as you can see, much bigger, no? 425 microns in the subfoveal area. Another good thing that I think it's very practice with subsource is that you can have the color tables. You can see that blue color means that the choroid is thinner than the normal. When the choroid is normal, it's green, and when it is thicker than the normal, it's red. You can also have the image of the fundus. As you can see here, you have a typical BKH fundus with sunset glow, peripapillary atrophy, and hyperplasia of pigment epithelium. Here is another example in whom she was a woman with the left eye was her best eye, and he could only see 10% with her best vision. The day before this visit, she said that he could feel a little bit of pain, but he was not conscious of having lost vision. The problem was, as she had a lot of posterior synechias, we couldn't do an ICGA because of the poor mydriasis, the cataract, and the vitreous haze. So thanks to SS-OCT, we could measure the choroidal thickness. Pre-relapse was only 187, and at the relapse, 604. So we could make the diagnosis of posterior relapse only with a SEP source. We couldn't do it in another way because even we couldn't see the fundus of the lady. Here is another interesting one. Here there is a bilateral relapse after tapering the treatment. In this case, here we were tapering the treatment. The choroid was still inflamed with 500 microns and 417. And in another visit, the patient came asymptomatic without loss of visual acuity, but we could see that the choroid was thicker with 680 microns and 478. So this was the most important way of knowing that we couldn't taper the treatment. So we stopped tapering until the next visit, where we could see that the choroid was not so thick, and then we decided to go on tapering the treatment. So in conclusion, we can say that automatic measurement of choroidal thickness with SEP-source OCT is a rapid, non-invasive manner of detecting posterior segment recurrences and treatment response in chronic BKH patients. We think also that SEP-source OCT could reduce the need for ICGA for monitor this illness. Thank you very much.
Thank you.